therefore, in so many ways, particularly wonderful to be here and see many old friends, as well as, because of my ties to Rhode Island, I've had the occasion of coming back frequently over the years, and really because of all the great work that's been done here, having the opportunity to watch what you've been doing, and on some occasions to get a little bit involved in what you're doing. So thank you all for putting on this conference, but also for giving me an opportunity to be here together. You've done a tremendous amount in Rhode Island on healthcare coverage. You, I think, are rightly able to say you are healthcare leaders and have been so for a really long time. You have a history of coverage that precedes what other states have done, and certainly precedes what the federal government has more recently enabled. You were really leaders in terms of expansion of coverage for children, expansions of coverage for parents, and for pregnant women. But you also focused a lot on the delivery system and making sure that the care people got was good care. And as many states started to look at enrolling kids with disabilities, for example, in the Medicaid program, lots of concerns, rightly so, about how were those kids going to be treated. And I would hear routinely from people, not just from those who provided the care, but from families in Rhode Island and those who served them, saying, you know, it's working. It's not only working, but it's actually good. It's good, strong, coordinated care. So you have a lot, I think, to feel proud about. And you're able to, I think, as a community, continue, and that's been your history as far as I can see, embrace new challenges, new opportunities to keep reinventing. We're always reinventing the Medicaid program, right? It's the occasion of the 50th anniversary of Medicaid in July. It'll be 50 years since the enactment of the Medicaid program. And you look back at what's gone on in Medicaid over those 50 years, in states, nationally, and it is constantly reinventing itself. And it's an incredibly, in some respects, complex program, but it makes it very nimble. It makes it amenable to thinking about it in new ways, better ways, and trying to always think about how to move forward. So the new challenges are that you're thinking about, the idea of how to deliver better care, how to get better health, and how to do that with lower costs. Those are not unique to Rhode Island, and those are not unique to the Medicaid program. That is, as the governor noted, lots of changes going on in the healthcare world in all sectors, commercial, private sector, the Medicaid, and it's going on in all states across the country, or nearly all states across the country. So there's lots to be learned. I was saying before the talk, Don Berwick, who's sort of the guru of improvement, and I had the pleasure of working with him while he was administrator of CMS for a while, and he always said, don't worry alone, right? Everybody's got problems. Come together and solve your problems together. And it's okay if you trip sometimes, because that's the only way that you know how to pick up and move on. So don't worry alone, and learn from all the things that have gone on in Rhode Island that have worked, some of which haven't worked. Why haven't they worked? We should be thinking about those, how to get them on a good trajectory to make them work, or maybe they didn't work because they were inherently really not the direction to go, and we should move on. Learn from what other states are doing. Again, not because they're always got the right answer, but because they've been trying as well, and they've got successes, and they've got lessons learned sometimes from their failures as well. So what I think we all know, and this was Linda's message as well, is it's worth the fight, it's worth the effort, it's worth the time, and it's worth the challenges. Getting better care, getting better health outcomes for people, and doing so in a way that helps healthcare be more sustainable is doable. I'm convinced it's doable. I'm convinced it's hard work. It's not going to be done overnight. It's not going to be done casually. It's not going to be done from top down. It's going to be done by all the kinds of people sitting in this room together and others around you, working together and really trying to continue to reinvent Medicaid as you've been doing for so long. So let me talk a little bit about I'm going to talk a little bit about the landscape in Medicaid. Linda's really done the lion's share of that work, so I want to talk in that section really about some of your cost drivers. Because if you have an eye towards where you want to go with an eye towards sustainability and healthcare costs, you want to look at what's driving those costs. And I will be the first one to say I'm probably not saying anything that most of the people in this room don't know, but it's good to remind ourselves of what those cost drivers are and what we've done and what's on the table. I also want to just at least take a minute to recognize where we've been on coverage and quality, and then move to moving forward. So if you want to move to the next slide. Partly why we're here is because Medicaid is a big part of our state budget, right? And there's different numbers always at different times for different purposes. So let me tell you why I picked out the analysis that I have here to share with you. This graph looks at Medicaid's share of total expenditures in the state of Rhode Island. So from all revenue sources, what does Rhode Island spend its money on? And you see, of course, that Medicaid is a very big share of costs. Here, it's about 28% of the budget, looking at all total expenditures. But look at that pull-out box, and this goes to the point that Linda was making before, which is that it's federally and state funded, right? And so when you look at that total expenditures in the state budget, what you realize is that the federal government is paying about 54%, which is about average for the nation, 54% of the cost. So looking at the next slide informs you in a different way. The next slide looks at Rhode Island expenditures using state sources, not your federal sources, right? Federal sources are in some ways a gift. They actually take pressure off your state budget because it means you've got some federal dollars coming in, spending on items that otherwise probably Rhode Island, given its long history of being a caring state, would probably end up spending state and local dollars. So federal dollars don't compete with education and other priorities that the state has. Federal dollars coming in from Medicaid actually take the pressure off the budget. So when you look at non-federal sources of state expenditures, Medicaid is still a large portion of the budget. It still doesn't go down to 3% of your budget, but it's very different, and it's 19%. So it's always, a complex story to think about Medicaid expenditures, and it's a big portion of the budget. It is also the largest single source of federal revenues coming into the state of Rhode Island. And that has a lot of benefit to everybody here in terms of funding services as well as generally to the economy. I'm going to move to the next slide. Okay, so let's look at what's been happening in terms of enrollment and costs. This looks at enrollment percentage growth, and this is looking at what we call performance indicators of the federal government was collecting, is collecting, so we actually have some data on what's happening in terms of the enrollment under the Affordable Care Act. And what you see here is something that I hope everybody, I know people in this room, but I hope everybody is proud of, which is that your enrollment growth has been robust. This is comparing state enrollment growth as a percentage of enrollment from right before the beginning of open enrollment. So really the period July through September of 2013. Open enrollment started in October of 2013. Comparing it, and this data brings you to February of this year. And so we see as a percentage of enrollment, Rhode Island has been growing. And it actually, when you look at the comparison in the other states, you see why it's growing much faster, for example, than Vermont and New York. Vermont and New York had already started covering the childless adults. New York had been covering childless adults for a long time. So the ACA didn't mean as much in terms of enrollment growth as it did in Rhode Island, which hadn't been covering the childless adults until you started under the ACA. So if you compare Rhode Island to lots of other states in that situation, you look more comparable, but I was looking at areas. But that's something to be proud of. We celebrate the idea that we are lowering the uninsured rate in the nation and in our state, and doing so very dramatically. That's, people talk about Medicaid, oh my God, it eats so much of the budget. It is doing so by insuring people. That's a good thing. That's not a bad thing, and as Linda pointed out, your per member per month costs have actually been going down. Again, doesn't mean it's not a big portion of the state budget, doesn't mean that we're not spending money that perhaps we should not be spending, or that we would spend more wisely. So let's look, and this goes to capturing some of the data that Linda referred to before, which is your percentage of your total Medicaid enrollees who are newly eligible. And this also points out the issue of where Rhode Island stood relative to those other states in terms of having covered people before or after the Affordable Care Act. So you see Vermont and Connecticut are states that were early expanders. Connecticut early expanders after the ACA. Vermont was covering some childless adults even before that. So a smaller portion of its enrollment growth are the newly eligible. Rhode Island is sort of in the middle of the pack in terms of this group, and a little higher than the nation as a whole. Of course, the nation as a whole includes some states that didn't expand at all. This is the group of people, this is the percentage of your new enrollment growth that is getting that 100% match. And it also tells you that, and this is something that I think is always important to keep in mind, that we had for years this notion of people who are eligible but not enrolled. And so what this tells you is, this is exciting, you're getting 100% match for this group of people, but it also means that some of your enrollment growth has been what we call from the welcome mat effect, because you have not just expanded eligibility, but you really simplified the way in which Medicaid eligibility is calculated. You have simplified the application process. You've coordinated that in a no wrong door way with your marketplace, with your exchange. And those kinds of changes, as well as just as importantly, changes to the renewal process, means that people who Rhode Island have long determined should be enrolled in the Medicaid program, are eligible for the Medicaid program, but maybe either didn't know they were eligible or found it difficult to enroll or to stay enrolled, have been successfully enrolling in the program and staying enrolled in the program. And that's really good. That's good because health insurance is a good thing. It's also good in terms of the delivery system reforms that you're thinking about. Because when you have people churning in and out of the coverage, when you have people who are not covered for part of the year and then come into coverage for part of the year, it is really hard to get to some of the challenges that you're trying to tackle in terms of reducing ED use, reducing preventable hospitalization. You need consistent coverage in order to make those delivery system changes work. Okay, so now we're going to start drilling down on where are the costs. I want to turn to the next slide. It's Medicaid expenditures per enrollee type, right? Which means Medicaid, as Linda went through, is a program that serves lots of different people in lots of different situations. So this is a common way of looking at a complex program, which is to divide up on a per enrollee basis how much we're spending on people who are 65 and older, elderly, disabled, adult population, and the child population. And this again compares to the same group of states that I've been using throughout these slides, as well as to the US average. And what you see is that in every state, not surprisingly, the elderly and people with disabilities are the higher cost groups. The other adults who aren't disabled or are elderly are lower cost, and children even lower cost still. And there's pretty dramatic difference between the per enrollee costs by eligibility type. When you look across the states, what you see is Rhode Island fits that pattern, right? Much higher cost for the elderly and disabled. And you're not the leaders of the pack in terms of highest per enrollee costs, not at all. But you're also not at the bottom of that per enrollee cost. And I think, continuing to drill down on what's going on for those individuals, you expect them to be higher cost. They are sicker. Right? They are always going to be higher cost. The question is, are we spending those dollars as wisely as possible? Are we giving them the best possible care that we can be giving them? Here's the other slide that I really want you to think about, because the slide before this, per enrollee costs for elderly and disabled, that's true with every state, right? Elderly and disabled, that's where the money is. That's where the healthcare is. That's where the healthcare is delivered. When you see Rhode Island compared in terms of expenditures relative to other states, this is the one that is different in that exacerbates the issue of why you often have higher costs in neighboring states. And that is because you have, as a population, more elderly and disabled people in your neighboring states, right? So elderly and disabled people are the more costly enrollees, and you've got more of them, just because of demographics in the state. So the combination of the two there, the high-cost groups and disproportionately Rhode Island's accounts, or it's Rhode Island's Medicaid population, has a lot of elderly and disabled people, will mean that your overall costs, if you just compare overall expenditures per enrollee, don't break it down, you will see that Rhode Island will stand out, but a lot of it is the prominence of that population within the group of Medicaid people Medicaid enrollees that you serve. So let's look at how then that all shakes out. This is the one version of the famous double bars that everybody likes to look at in the Medicaid program because I think it's pretty stunning, right? This looks like what you have is enrollment on the left side by those same groups, right? By those same groups, and then on the other bar you have expenditures. And what you see is that while children and adults, children and families are the largest group of enrollees, they are the smallest share of costs, and again, not surprising, elderly people and people with disabilities have high medical needs. They comprise 31% of enrollment and drive 74% of the costs. And if you go to the next slide, if you do further breakdown, and I know you all have been looking at this, 7% of enrollees account for 66% of all your expenditures in the program. That's pretty remarkable. It is not unique, okay? It is not unique. Nationwide, 3% of enrollees account for 54% of all expenditures. So I've not seen this particular 7% breakdown compared to other states, but it is not unique. We have in our healthcare system generally, and in our Medicaid program in particular, very skewed use of healthcare services. Some people don't use a lot of healthcare services. Some people use a fair amount, and some people, a small number of people, use an extraordinary amount of healthcare services. And again, sorting out why they use that, is part of our challenge. Is it because they're very costly, very high healthcare needs, day-to-day chemotherapy, lots of things that need to happen, or are we bouncing them around between, different facilities? Are they going to the emergency room when they shouldn't? Do they have behavioral health problems over here and physical health problems over here, and never the twain shall meet in terms of the delivery of their care? What is driving those costs? Because I can guarantee you, and I think everybody in this room knows, that some of those high cost enrollees are not getting the most integrated, the most value-driven kind of care that we all would want our family members to get. So, penetration of managed care, if you want to look at go to the next slide. As again, Linda pointed out, we have a lot of managed care in Rhode Island. You were one of the first states to do managed care. And when I say to do managed care, because it's a term of art, I guess I would say to enroll people through a capitated system where managed care organizations have the responsibility to serve them using the capitated payment rate, right? Is care being managed? How well is care being managed? What's happening within managed care organizations? That's a question that you'll all want to think about, right? And I know that you are thinking about. But you start with a base of a very strong, a strong infrastructure of people being in a managed care environment. That being said, if you look at these bars, you see that there are some populations, your adults with disability and certainly your elderly, who are not in managed care environments. And maybe that's a good thing, and maybe they would benefit from some better management of their care. And we're going to get to that in a couple of minutes. If you look at MCO, managed care organization enrollment by expenditures, it drills down on really who's out of that equation of being enrolled into managed care, and it shows that 23% of enrollees who aren't managed care account for 51 of your expenditures. Again, not surprising, we just showed the bar graph saying people with disabilities are disproportionately relative to the rest of your population, and certainly the elderly, not in managed care. So not surprising that that the non-managed care people would account for a lot of your expenditures. Those, again, are the costly members of your Medicaid program. Let me just briefly show you this slide, which is where your expenditures are going by provider type. First of all, assuming these data are accurate, I want to commend you for having these data. Many states do not have encounter data, and many states with large penetration of managed care don't know exactly where that money's going. It's the black hole of our data. So it's really good to have this picture, and it tells you some things. I think, frankly, the thing that strikes me most when I look at it, some of this stuff is pretty reflective of the nation as a whole and other states in particular. But if you look at the home and community-based care relative to where your long-term care service dollars are going in nursing homes, it's pretty stark, differential. And nationwide, the last data that are available nationwide, which is 2013, and I think we will see a big change when we finally get to 2015 data. About 46% of the dollars in long-term services and supports are now being spent nationwide in home and community-based settings. And I think all of us recognize, of course, there are many people for whom nursing home care is the right and the appropriate care. No question about it. My family knows that as well as every family out there sitting here. At the same time, we never want a situation where somebody who needs long-term services and supports finds themselves in the situation where the only way they can access it is by going into a nursing home when they are perfectly able to continue living with their families in their homes and in their communities. So the choice ought to be on what's the best and most appropriate care setting for an individual and family. And that's, I think we would all agree, it's hard to get there. It's hard to get there, but one area where I think really calls out for a lot of good thinking here. So the next slide just looks at some of the next two slides. I want to just briefly remind us of your progress on coverage. Linda was saying that this slide made her wonder. You love this slide. She loves this slide. It did make her wonder. It did make her wonder. Well, first of all, it should all make you really proud in terms of the uninsured rate. You're really doing great, and this breaks down a lot of the things that Linda also talked about in terms of where your buckets of enrollment are. But you also should be very proud, and I know many of you who have worked on this over the years are in this audience today. If you want to look at the next slide, you're also a state that's paid attention to quality. You had quality metrics in your managed care contracts before other people even thought of that idea. You not only measured, but you've been seeing some good results along the way. So that goes back to build on your strengths, figure out what makes things work, figure out what hasn't worked, and what needs to happen moving forward, which brings us to where we are. So I've looked through your work group proposals and have some comments about it. You are the experts on it. We can have more conversations about it. I'm not going to get into details. What I want to at least start with is a framework, and again, this is going to be familiar to you, right? As you continue to move forward, understand your cost drivers, right? Understand your cost drivers. And I say that not just because you're about cutting costs. I say that because if you're looking to improve care, if you're looking to integrate delivery of care, if you're looking to improve health outcomes, the people who are the highest utilizers of care are probably most at risk of not having the kind of integrated, effective delivery of services that we all want to see. And it will also bring you to where can we achieve the savings that I think is also on certainly a lot of people's minds. Build on the initiatives underway that are working. If some aren't working, throw them aside. I know we all get attached to our projects, but if they aren't working, throw them aside. It's hard. If they're not working because they just didn't really get off the ground, but they are terrific, then dust them off and say, you know, remember that terrific idea that we got distracted because we were doing X, Y, and Z? Let's go back to that. So think about what you've done. There's a lot here to build on. And really big advice here, because it's hard, is coordinate. There is a real tendency to say, oh, we could do this, and we could do this, and we could do this, and we could do this. And you have initiative fatigue, and you don't step back and say, what are we trying to achieve? Because if we're trying to get preventable hospitalizations reduced over here, and we're trying to improve primary care over here, don't those two things really go together? If we're trying to integrate behavioral health and physical health, and we're trying to reduce hospitalization over here, don't those three things now go together? And if you don't think of the interconnections of those pieces, you are likely not to be successful in each of the siloed initiatives, but you're certain not to be as effective as you could be with good coordination. And then most importantly, because we want to save the most important for last, you know, there is something special about Medicaid, and that is the population that we serve in the Medicaid program. They have unique needs. They are poorer, they are sicker, they work in jobs that don't give them the flexibility to just take time off and go to the doctor at times that other people might be able to go to the doctor. They don't have, by definition, they don't have the money to pay out-of-pocket costs that people with more money will have to pay out-of-pocket costs. There's lots of factors that will affect how to design a delivery system that works, not just generally, but works specifically for the population that we're about serving. It makes no sense to design a really cool system and it's a mismatch to the needs of the population that we work with. So the next slide is just to show the point that I was trying to say a minute ago, which is when I look at the work group proposals, and you very smartly got them into paths, yes, buckets, groupings, and that's a really good way to do it, and that shows you're thinking about that coordination, you're thinking about how they link together, right? There's a lot around the system reform, for example. But there's, within those buckets, you need to weave them together, and then I see some things in other buckets, and I'm sure you do as well, which very much interrelate with other buckets. So again, it just means as you're thinking about this next stage of your work, think about, step back, where do you want to go, how are you going to get there, and then how do these pieces interact, help you get there, what's missing, where you need to fill in the gaps. So I'm just going to talk a little bit about a few different things that are either underway in Rhode Island or are partly underway or could be underway. One is your Integrated Care Initiative, which is what we call it CMS, a dual demonstration. And some 40% of your spending is on people who are enrollees in the Medicare program. Medicaid fills in the gap for Medicare. Medicare, this is not because, you know, I spent 5.5 years at CMS saying, Medicaid, Medicaid, when everybody wanted to talk about Medicare, but bear with me for a minute. Medicaid helps Medicare work. It fills in the gap for cost sharing and premiums. Medicaid pays that for local Medicare medical expenses. And it fills in the gap on services, most notably long-term services and supports, which are part of the Medicaid program. Which are part of the Medicare program. Secretary Sebelius, a governor, former governor of Kansas, came into the administration and she said, first meeting I had with her before I was hired, first meeting, she said, what about those duals? I've got the highest cost people in my Medicaid program, and the primary care is paid for by Medicare. I can't control that. You tell me to invest in greater reductions, improvements in care, and which will result in reductions in hospitalization. That benefits the Medicare program, which is paying for the hospital part of their care. The rules aren't aligned. There's no way to both manage care and to do so in a way that saves costs for the state government. unless you align not just the care delivery system, but also financial arrangements. And so setting up the duals initiative was a real priority for us, and it makes a tremendous amount of sense. You are finishing you're in phase 1, and you are about, as I understand, to hit on phase 2. My experience with the states that have moved ahead on their duals demonstration is that it's enormously exciting. It is really hard work, and so important. It goes back to exactly what we were talking about, the people who are high medical needs folks, who are largely in uncoordinated care and have the double whammy of having their coverage come from 2 programs who historically have not talked much together with each other and not worked together. So it's tough, it's hard work, and I salute you for having been going forward with the duals demonstration and embarking on this, and really look forward to seeing some great results on that for people. Really some great results for people. If you, next slide looks at long-term care opportunities. There's a lot of items in the work group proposals that are aimed at improving and strengthening your home community-based services. The services provided, the home care services provided, the governor talked about that as an initiative. Those are all really important. I would suggest you really want to think about how are we dealing generally with long-term services and supports, and then how are we integrating them overall with our care. If you think about, for example, people with disabilities, and you think about, I'm going to help reduce preventable hospitalizations, that's an activity over here, and then long-term care is an activity over here, not so much. It won't work unless you are very much integrating those systems, unless you are thinking about what your discharge policies, and, you know, people with disabilities we would meet with regularly in a group. And I'll never forget one of the leaders of the group had said to me, you know, it is too late for somebody with disabilities to think about their discharge planning when they go into the hospital. They have to think about discharge planning well before that, because you'll lose your caregiver, you'll lose your opportunities to be able to get quickly back into the community. So discharge planning is not like, oh, I see you leaving the hospital, let's make sure you've got something in place. It's really part of delivering a patient-centered system of care. You have a waiver that you got approval for in 2009, which I'm not sure has moved forward, so it might be one of those things to at least think about. This idea that Tennessee has implemented, following Rhode Island, it said, oh, Rhode Island has this great waiver, I want to do that. Which is basically people walk in and say, I need long-term services and support, they get assessed for what they need, and instead of saying, well, you go to the nursing home if you meet that, if you meet that standard, and maybe we have some slots over here on a home community base, and maybe we have a long waiting list, it puts those services on parity. And it's a little risky business, right? Because there's a sense that, oh, everybody's going to come out of the woodwork and use long-term service, use home and community-based services. It's worked really well in Tennessee. It is still a work in progress. No one can ever say, oh, they fix that. But that's their approach, and it really helps. And one of my pet peeves is, you know, people talking about rebalancing the long-term services and support system. We've never had it balanced. So we have to achieve that balance of getting it more in line. So Tennessee has been doing some interesting things. Washington and Oregon have been leaders for years in really building a strong home and community-based care system, and one which is connected well to what's going on the rest of the parts of the person. I also want to point out Rhode Island is one of the earlier states, if you want to move to the next slide, thank you, to do health home state plan amendment. Some maybe have worked out well, some maybe haven't worked out well. I'm not knowledgeable enough, so I'm not necessarily saying, you know, what you've done is terrific or what you've done should just go forward. What I'm reminding you is that there's 90% federal match for care coordination for 8 quarters. You can keep doing it. You can come up with different areas of doing health homes. You can do it inside managed care, you can do it outside managed care, lots of ways in which you can do it. So those opportunities are still there. You know how to do it. You've been working on it. I also want to mention that as you think about what's going on in the world of Medicaid, of course you need to think about all payers. Because while we've got our people with disabilities and our elderly population. People with disabilities might be in the commercial sector. A lot of them are only in the Medicaid and some in the Medicare insurance, and same with the elderly. But our adults, our families with children, they are in and out of the marketplace. They're in and out of employer-based coverage and Medicaid coverage. Life is not static. Life is dynamic. It doesn't stay the same for people. And so for them, it makes a big difference to think about alignment, but also really, if you are the famous, analogy, if you're all rowing in the same direction, we can get there a lot faster. So the delivery system and payment reforms that you're thinking about around the, non-disabled adults and children's sector really have to be lined up with what's going on in the commercial world. Again, we have a special, unique population. It's not going to be all the same. But you start off with, how can we move in a similar direction? And you'll see some new managed care regs come out of CMS pretty soonish, as they say. And alignment across markets is a real issue, because we could also make rules at the federal level that make it harder for commercial payers, Medicaid plans to be able to work together, and for providers to be able to comply with different crazy rules from different crazy sources. So finally, in terms of what I want to mention, is it's always on people's mind, and it should be, where are the opportunities to maximize your federal matching opportunities? I mentioned health homes, because you can get the 90% match for care coordination for 8 quarters. Community first choice, I think people may have looked at it when it first came out. It is new. The Affordable Care Act isn't so new anymore, right? It is an option that was created in the Affordable Care Act. It really goes to what I was saying before about long-term services and supports and getting parity, assessing people and saying, go to whichever way the service is the appropriate place, setting for the services to be provided. It does give some enhanced match for doing that, and so we only have a couple of states doing it. It's a heavy lift. But it is one, if it's the direction that you want to be headed, it's one you want to look at to see whether it also has the benefit of giving you some additional federal dollars. Incarcerated individuals, I hear you're doing some work on this, both making sure people, when they're, now that you've covered childless adults, when they're in prison, Medicaid will cover inpatient, not other care, inpatient, hospitalization under, it's got to be outside the prison settings, and it's got to be a real hospital kind of thing. So you can draw down some federal dollars for expenditures that you might have been shouldering in other ways. And just as important, or maybe more important, right, is to make sure nobody leaves jail without being assessed for health care coverage, right? They should be eligible. If you've got somebody who needs prescriptions, who needs primary care, who needs specialty care, as so many people do as they're leaving that situation, you don't want to create a gap in coverage. You want to make sure it's there for them from the very beginning. That has enormous value, both economically, but certainly in terms of their lives. A couple of other things. There's one hidden thing that a lot of states don't take advantage of is translation services. Very important in Rhode Island. You can get a 75% match for children to provide translation services. So if their children come along with the parents, there's a way of doing that too. So just want to flag that. In the change in federal rules, which gave higher match for eligibility systems, that also extends to eligibility workers. I don't know if you're taking advantage of the 75% match or doing it in a way that's possible. And I think there's lots of it. I saw in some of the comments raised by Neighborhood Health Plan and some others. There's lots of ways in which some of the administrative tasks, either the managed care organizations are doing, or that you've identified, like potentially predictive modeling, maybe not, depending upon how it's done. You might be able to take advantage of an enhanced match rate for some administrative services that otherwise are at a straight 50-50 match. Those are just some. There's many other gurus here that I think can help you think about those. So let me just end by sort of a little bit where I started. If you want to go to the last slide, or the next to last slide, is you're not alone. People around the country are thinking about this. Not everybody, right? But leaders like Rhode Island are thinking about this. And there's lots to be learned. No state is like another state, right? I have governors tell me all the time, like, you gave a waiver to that state, I want that same waiver. They don't really want that same waiver. They never ask for that same waiver. And they shouldn't, because every state is different, right? Your needs, your infrastructure, your market, everything is different. But there's lots to be learned from what's going on in other states. We have a major effort going on. It's no doubt increased by a lot of money that we provided through a waiver to New York. In New York, on delivery system. Primary goal, reduce preventable hospitalizations, reduce costs through preventable hospitalizations, and big partnerships starting to emerge in New York between hospitals and community-based providers, behavioral health, physical health, working through what those relationships ought to look like. How do you look at total cost of care? How do you attribute patients to those new partnerships? How do you design metrics that will know whether you're serving people better, and then share some savings if you're successful? Colorado has embarked on accountable care organizations and within its Medicaid program, and has a history of not having commercial managed care organizations in the state, and is looking in a different direction, which is accountable care organizations. Oregon is doing a really interesting effort. It calls them community care organizations. They really are managed care organizations, at least legally, but they're called community care organizations, and very regionally designed. Very regionally, priorities are designed regionally. A lot of reliance on non-traditional care providers, just you'll look in June for the report that's coming out from Oregon on their early data and what's happened over the first couple of years of their initiative. And others here, Illinois is looking for accountable care entities. Illinois has actually done some interesting things, particularly in Cook County. There's been some interesting developments in that very large public hospital system. And Alabama is in the process right now of working on across the table on with different payers to think about how to do various ways in which they will bundle payments and they really kind of want to do Oregon in Alabama and have community care organizations coordinating and providing care. So that's very much a work in progress. Lots of other examples here. I wanted to give you a couple of examples too. These are what I gave you before, really deep inside the Medicaid program. There's also a couple of examples of Medicaid being strong partners, sometimes leaders on the multi-payer front. One example is Arkansas. They are developing with the commercial players, mostly the Blues, and their state employee systems and the Medicaid program, and trying to get Medicare to the table as well, on bundled payments. They're a fee-for-service state, very uncoordinated care for their Medicaid population that's not newly eligible. So their way of reforming and reinventing Medicaid for that population is very much hand in hand with what's going on with the other payers. They're not going to pay the same, they're not going to have exactly the same networks, but they're going to have the same way of thinking about packaging bundles of care and pricing them at least, through the same methodology, even if not exactly at the same level. And Tennessee Healthcare Innovation, in addition to long-term care, is also looking at episodes of care similar in some respects to what's going on in Arkansas. So lots of things going on, lots of history here. I want to thank you for your attention, but also mostly thank you for all the things you've done over the years, and for your continued dedicated commitment to always reinventing Medicaid, always making it work, and making it work better. So thanks very much.